Hello, my name is Sharrie Harlin. I'm the Community Outreach Coordinator and Program Host for Reid Beside You. Today, our guest is Dr. Mario Lee from Reid Orthopedics.
Hi, how are you?
Welcome, Dr. Lee.
Good to be here.
First, wanted to just give an introduction. And how long have you been with Reid Health?
Well, I've been with Reid for 10 years.
Okay.
It's been quite a very interesting and very fun-filled ride so far. I was the first Reid Health employee.
Reid Health for the
Reid,
physicians.
Yep.
Associates.
Out of all the
That's
physicians
great.
that have been employed, it's been a quick 10 years.
Oh, great. Then today we're discussing just some of your specialties, and the first thing I would like to ask you, what's some of the differences as we're looking into orthopedics? There's a lot of different areas. Probably the biggest things people are used to hearing, like knee replacements, hip replacements. But today we're looking at some of the main causes. And probably the first thing I'd ask you, what's the difference between arthritis and osteoporosis? Because that seems to be a common theme, and people seem to end up to visit you when they've had those diseases. So,
yeah, joint pain is pretty common, even young and old, and the older set of population. There can be various different causes of pain. And I think one of the common questions that I get in the beginning is just to clear up any types of misunderstanding is, what is arthritis, and is it the same as osteoporosis?
What are the differences?
So arthritis, I think in the way I'd like to tell people is just wear and tear. So arthritis in most patients would be like if you drive your car, slowly as you go through wear and tear, your tires wear down. So arthritis would mean that the joint itself wears down and then the causing of pain. Whereas osteoporosis is a completely different pathology where that's a thinning of the bone, and that actually puts you at risk for a break of the bone. So two different causes, they'll present very differently. So that's one of the things that I like to talk about. Well, what's the difference? Because they have some questions and I think they get them mixed up.
And what's the biggest when it looks like the problems happen most when it's undiagnosed? So just like if you don't get your car serviced, you're not getting your body serviced.
And I think a good way to kind of start out is maybe with the normal anatomy of a joint. And I'll use the hip, but it can be really used for anything.
So great. So give us some examples of the anatomy of the hip.
So the anatomy of the hip is essentially a ball and cup. So we see the cup portion and the ball portion. And the blue is actually depicting good, healthy cartilage. It's thick, it's smooth, it's rubbery. It really allows things to kind of move real nicely. Now, as wear and tear or even fractures or even other diseases, over time you can have the cartilage wear out. And in this situation, you can see that the blue part, which is the nice, healthy cartilage, starts to wear down. And therefore, you get to the point where you almost get bone grinding on bone.
Okay.
So the most common presenting symptoms would be obviously alternating between sharp stabbing pain to a dull aching pain. They can also have a grinding sensation in their hips, difficulty moving around in the morning, so they sense a stiffness. And a lot of times they like to have difficulty just getting up in the morning when cold weather comes.
Right.
So they feel like, getting started for the day will be a lot more difficult. Okay.
And so that's what. So what causes the pain?
Well, the causing of the pain is once it's worn down and the good healthy cartilage, then you have the bone grinding on bone, and then you have the nerve endings really kind of causing that kind of pain. Also, as a reaction to the arthritis, you're going to have some bone spurs, and patients actually will get limited motion. So they'll end up having some limping, they'll favor it. Amazingly, they'll kind of even walk very with a limp, and they don't even know it because it almost becomes part of their daily life. Yeah.
And so it's estimated over 70 million people in the United States have some form of arthritis.
Yep. Our population, we're living a lot longer. We're being more active. And as some patients will undergo some type of surgical procedure at a young age, given that and also the aging population, you're definitely seeing more and more patients who are presenting with some type of arthritic type of pain, and they kind of want to know what your options are.
Right.
Surgical versus non-surgical options, and what are the things that you can do.
So osteoarthritis is a very common form of arthritis.
Yes, it is the most common form of
Okay.
arthritis, where you get the most normal wear and tear. And people also ask, what's the difference between osteoarthritis and rheumatoid arthritis?
Right.
Rheumatoid arthritis is really when the body attacks itself. So it causes inflammation and destructions of the joints. Fortunately, that's a very small percentage of the patients who present with arthritis. And so meeting your doctor, having some blood work, having some x-rays, having a good history and physical, will be able to distinguish between a rheumatoid arthritis, which is a form of inflammatory arthritis, versus osteoarthritis, which in most cases would be just normal wear and tear. Since we're getting older, just like my analogy be with tires, you drive long enough, eventually your tires wear down. Unfortunately, we can't slap rubber back on a tire, so that is a similar situation.
And some of the forms of treatment.
Yes. Well, I think in the United States, the phenomenon that could be multifactorial. So part of it is genetic.
Okay.
There is a genetic predisposition for some patients to develop wear and tear at a much younger age. If you allow me, the analogy would be not all tires are made the same.
Right.
Some are much better quality than others, and they will last longer. So that is that genetic component. Also, the kind of lifestyle that you lead. Have you been really hard on your joints so they wear down faster? So that's a contributing factor also. If you had previous surgery, will also contribute to see that your cartilage has worn down much earlier. Some patients who undergo some type of trauma like a car accident and they had a crack in the ball and cup and they had to fix it, they will develop post-traumatic arthritis at a much younger age. Also, a big contributing factor is your medical issues and your weight, because obesity is such a incredibly demographic issue that we have to address these days. And as the population does get heavier, it puts more wear and tear. So imagine putting a tire that it's meant for Volkswagen, you put it on a big Ford
SUV.
F-150 truck,
Right.
you can see how that tire is going to undergo wear and tear at a much faster rate. So that is a big contributing factor and something that's multifactorial that you try to address even before surgery, because the healthier you are, even leading up to surgery, will make your recovery and the risk of surgery much less.
Well, in that case, so a person who was obese, would you suggest they lose weight before the surgery or exercise more?
And that's all very good questions, and I would say absolutely yes. The more you can medically optimize a patient leading up to surgery, the better they will do. When we perform surgery, they're giving us that privilege of being part of their livelihood. And we want to try to do as much as we can to have them have a good surgery and have a good outcome. We never want to perform surgery on someone who does not have a good outcome. So in general, you want to do as much as we can from a medical, lifestyle type of issue to see what best they can do to do as well as they can.
So that's why it's so important to be very honest with your physician, correct?
Yes, certainly, and a lot of times you'll see patients who didn't know they had diabetes. Sometimes they'll come in and they get the routine blood work and we send them off to get them medically cleared and their blood sugars are 300 to 400. Well, it's not an emergency surgery. Let's get your blood sugar under control, which is very critical and also will have a big effect on the risk of surgery and the risk of infection and even having wound problems. So all that is really trying to be medically optimized before surgery.
Another group of people, I'm sure you see a lot, ex-athletes or people that run a lot and put some stress on their joints. So,
yes, certainly you do have a subset of patients who have been very hard on their joints. And so they'll present at a much younger age just
Okay.
because they worn out all their joints. There is a kind of a myth to believe that I'm too young for a joint replacement. Well, joint replacement is really, once you've tried all non-surgical methods and they failed, and they're at a point in their life where their quality of life is compromised, you know, you base it on their need, not upon their age. So I have patients as young as 28 years old
Really?
who've had a hip or knee replacement, and I've had a patient who was 107 and I did her hip replacement. So it's not based on age,
Okay.
it's really based on their need and their function. So it can really go a spectrum. That's almost a 80-year difference between 28
yes.
and 107. So it's been amazing. Even last year, we had half a hip replacement performed on patients with fractures. There were 4 of them over 100. So having 4 centenarians in 1 year, that was pretty amazing
That's
last
amazing.
year. Yeah.
And that's helping their quality of life, sir.
Oh, yeah. I mean, I think that's one of the most gratifying things as an orthopedic surgeon is that patients really feel their quality of life is compromised. And to give them back their quality of life, professionally and morally, it's very satisfying because you are involved in this process and you're part of their life, and to see them being able to do a lot of things they enjoy, such as even taking a simple walk with their dogs or their grandkids without having pain, it's very, very satisfying.
And part of it on the treatment, we discussed more of the surgical side, but the non-pharmacological, if they're eating better. Did you touch on that? Or?
Yeah, so certainly leading up to non-surgical treatments from a standpoint of just eating better, having a healthier lifestyle. And then once you go beyond that, if you require some type of pharmacological treatment, there are various things you can do. So a lot of patients do start out with Tylenol, even Advil or Naproxen or Aleve. And then you can even do some type of steroid injections into the hip joint or the knee joint to help with lubrication of the joint and trying to reduce the inflammation. So those are all things that you can do that are non-surgical. Injections into the joints are relatively a benign procedure. They're not too much risk, pretty quick and out. And so those are all things you can lead up to it. But at some point, you feel like you've tried everything,
right?
And that's then you're going to say, okay, I think what is the next step for me? So a lot of times, hopefully, we would have developed a relationship with the patient at this point, because once they come across that bridge, they're ready to cross that road. We'd like to be there with them, and it's usually better to develop that relationship earlier on. That way, you know you're optimizing everything you can before.
So we're trying everything to reduce it. So whatever treatment options before the actual replacement or surgery. So we're looking at the non-surgical options as much as possible.
Yeah, those are some options, and there are some patients who will present very late, who kind of worn down all the cartilage. There's just nothing left, and their quality of life is really, really so. At some point, you will have patients who are just ready for hip replacement.
And once again, that age can vary.
Oh yeah, tremendously.
Depending on when
really
they
their
present
need
to
and
you.
function, yes.
So once again, I always like to remind people how important it is to have your regular visits, so that you don't wait until the last minute, that you have other options.
Yes, because waiting or delaying surgery too long when you feel like it's been shown that they don't recover as quickly. So you don't want to wait until half an inch of bone is just really worn down. So they become very kind of sedentary. They've actually become weakened because they're not moving it around as much. Their muscles become weaker, and some even become confined to a wheelchair. So obviously it's very hard to do a joint replacement when you've kind of waited that long and gone beyond to kind of being able to do the best after a joint replacement surgery.
So are most of your patients referrals from from a primary care doctor, or just an individual will understand it
Yeah.
just because of the pain?
A lot of it is just word of mouth. Certainly once, most of the referrals are always word of mouth. Once a doctor establishes themselves in the community, and being here 10 years, a lot of it is word of mouth.
Right.
Now, it's not to say that any joint replacement surgery is free from complications, but you try to do as best as you can for the patient because you want them to do well. And obviously, as time passes, the word of mouth goes from one physician or even patient population, and then ultimately you get a good referral source.
So we've looked at some of the causes and reasons why people so just exactly what is hip replacement?
So hip replacement in this scenario, I showed you that one model where you feel that the cartilage is worn down, and then you start having bone on bone. Well, the basic idea is if the ball and cup grinds and causes pain, well, let's remove and replace the ball and cup. So in this scenario, I'll show you a smaller model first,
Okay.
where you're cutting out the ball part and putting in this artificial component here on the ball. And the cup, you can see that you're putting a metal cup and a liner on the inside. So that way you don't have your own bone grinding against your own cup, but now you have an artificial ball smoothly moving around a artificial cup. So in this bigger model that I have right here, which is a translucent model, that you have the artificial ball and it's inside the bone, and then you have this artificial cup with artificial liner, and then now you have a smooth ball moving inside a smooth cup. So the basic idea is if bone is grinding on bone, remove them and then just replace them artificially, and that way they can get their quality of life back.
With the, what's the typical lifespan of the surgery?
So the typical lifespan, most studies would suggest they're anywhere from 15 to 20 years. And there are various approaches you can do for hip replacement, one being an anterior approach and one being a lateral or posterior approach.
So explain the most popular, what people are normally used to hearing have been the posterior approach.
So
can you explain that for us?
If this is the front of the hip, if this would be the front of your pelvis bone on your left side, an anterior approach would be one that you come through the front, and a posterior approach would be one that comes from either the side here or a little bit back there. Traditionally and most popular has been a classical posterior approach, but that cuts through some muscles. You have to cut through some various ligaments to get down to the hip replacement, to do the hip replacement, whereas another approach is going through the front. Now, the anterior approach is a different approach, but in some ways, a much more efficient approach because it does not cut through muscles. It separates two sets of muscles, and you're basically, once you separate those two sets of muscles, you're directly into the hip joint. Also, because of the way the anterior is done, you do x-rays inside surgery to really kind of perfect the position of the cup and the ball. So there are certainly advantages because the recovery is usually much quicker because you're not cutting muscle. You're still going to have surgery pain, but the recovery tends to be much quicker. And because the position and everything is so much more exact, I can usually get it within 1 to 2 millimeters.
Wow.
Now, 1 to 2 millimeters, it's an amazing amount, but you can really be exact as to the positioning of the ball and cup.
Now, and with that, can you explain Do you use a very different type of table or X-rays? Can you explain
Yes.
that to us?
So through the anterior approach, you use a table that our hospital has bought us 7 years ago. It really allows the visualization and then optimize the angle at which we can try to get to the hip replacement. So that is one advantage. The other advantage is that because they're on their back as opposed to being on their side, that you can use an X-ray machine going in and out, and I can really get exact positioning of the ball and cup, because you want to restore the patient's anatomy. Everybody's hip is different. There are very subtle differences, so you want to reproduce their anatomy as close as possible because you want their hip to feel as natural as possible. So the closer you reproduce it, the more natural feeling the hip replacement will be.
What and how do you determine if you're going to use the traditional or the anterior approach?
Yeah, and that's, I think, a relationship that you have with your doctor, because not everybody is a candidate for one or the other. Certainly the body shape, medical issues, quality of their bone, that all has to be taken into account before you determine if you're a good candidate for the anterior or the posterior approach. And which I do both, though.
Okay. And approximately how many surgeries do you do for just the back surgeries a year? Just yourself, I know.
Yeah, we have a great group of guys. We're all very high volume surgeons. We're all easily doing over 500 cases a year.
Wow.
So there's just a lot of broken bones, a lot of sports injuries, and a lot of joint replacements in this area. So we're all very well experienced. All of us easily have over 10 plus years experience.
Well, that's good to know. Let's go and speak about rehab, because a lot, the differences just in the last 5 or 10 years, when people would say they were having back surgery, the amount of time that even just to stay in the hospital before they either went to rehab or went home was a lot longer. I've seen people that have back surgery and they've been released almost in 24, 48 hours.
Yeah, in back surgeries in general, yes, but all of orthopedics, I don't do any backs, but joint replacement surgery.
Right.
At Reid, we have what we incorporate a joint program where we have not only standardized the rehab process, but having a dedicated team for joint replacement surgery. So once we instituted that approximately almost 8 years ago now, the success that we've had in trying to optimize the patients even before surgery,
Right.
in surgery, and after surgery has been tremendous. So we're one of the top in the state of Indiana, and we're certainly up there compared to national numbers of how well the patients do for joints in surgery. It's interesting that the more you expect patients to do from a rehab standpoint, the more they will do and respond. Gradually, part of it is also because of Medicare. You are seeing a certain percentage of patients who are a little bit healthier to actually even do outpatient joint replacement surgery, which is an amazing thing to even consider. Even when I did my training 15 years ago,
Right.
that patients would have surgery in the morning, they get a little bit of rehab, make sure there's no bleeding, and they get discharged at the end of the day. So that is something that you have to determine if you would even qualify. So that's something you discuss with your doctor. Are you even a candidate for it? And some patients even want bilateral joint replacement. So those are all discussions you want to develop with your doctor.
And once again, I want to reiterate, it's amazing that people will come in to have that surgery. And as a person who at one point would go in to check on, especially some of the Medicare patients out, how are they doing, signing paperwork, we have to get there pretty quickly, because some people, the time that they're released, we can't even get there.
Yeah, it's pretty, yes, as long as, just since we did the joint program, we've really been able to be much more efficient. Even taking the mysteries out of what joint replacement is like, we give the patients a book to what to expect, and then even having a checklist for all their appointments. So trying to standardize everything, we've really done a great job and being able to make this joint program pretty efficient.
Oh, great. I just wanted to look at some of but basically the myths of joint replacement. Once again, people think they're too young for a joint replacement, or how long do they wait for the surgeries, or I'm too young.
Okay. With respect to being too young or even being too old, I tell them it's really based on need. The younger patients, they tend to be either some type of previous trauma or they had some type of congenital disease. So that will make them much a younger candidate for joint replacement. But once again, it's not based on necessarily age, but their function and need. So as someone who's even over 100, you know, you're not too old. If you're very functional and lead a great quality of life, but this joint is just kind of hurting you, you address it as appropriately based on their function and need, not based on age. So I think that's just a big myth that you kind of want to debunk. Also, you know, when you meet an orthopedic surgeon, you develop a relationship. They'll talk to you about what your options are. Some patients are very advanced, so they kind of present at a point where they feel they're ready for it. And there are other set of patients who feel like maybe, you know what, we can try all these non-surgical options. Let's get you hooked up into a nutritionist, physical therapy, weight loss program. Let's make sure you have a primary care doctor because you have these medical needs and you have to address them. So, yes, it is better to come in early to develop a relationship, get a history and physical and see what your diagnosis is and see what your options are.
Great. And Dr. Lee, as we close, we wanted to make sure that that the community is aware of your location and your probably the best way locally people know it's like the Reid Orthopedics is behind or the exit behind our local wing place.
Yeah. We're Reid Orthopedics. We're all employees of Reid Hospital.
Okay.
Certainly you can contact us. You can call the main hospital and they can get you to Reid Orthopedics. But we're at 1400 Highland Road, which is, if you get off on the highway, it's right next to the big water tank.
Right.
We have our own dedicated building. We have both physiatry and pain management, and also podiatry with Dr. Bill there also. So we have a nice group of people. A lot of us have been together for a long time, so we're pretty well established. Certainly you don't always need a referral, but you can call us and we can make the appropriate recommendations, or you can talk to your primary care physician, ask them to see, you know, I've been having a lot of pain or joints. I would like someone to discuss with, and they can easily set up a referral for us.
Okay, well, great. And we have enjoyed having Dr. Lee on Reid Beside You this week, and they can also make sure we can contact you at Reid Orthopedics, and we'll have the number on the screen. Thank you very much.
Thank you very much.
Thank you for watching this episode of Reid Beside You.